can follow up with support. Hello, good morning.
How
How are you, Hannah?
Good, how are you?
Good, thank you. All right, I think we're all set up. Matt is just in the auditorium behind us.
Yeah, I just texted him.
Okay. All right. He hasn't joined yet, so give me a sec. I'm just gonna go check on him, okay?
All right, so that's what everyone else sees?
That is, yeah.
Okay, perfect.
Okay, so you got your speaker all straight?
Yeah, I'll just test the mic right now.
Sure, yeah, sounds good.
Test.
Perfect. Yeah, I can hear you here, Matt.
Okay, perfect.
All right, so usually how it works is Dr. Stadnik will join and do the introductory. And then after that, she'll hand it over to you. You can go ahead and kind of do your thing. At the very end, we do Q&A, and how it works is that people will just kind of throw up their hands and we'll unmute them, and they have an opportunity to speak to you, to ask a question, you respond, and people also have the ability to add comments if they don't want to actually speak. So we just monitor the comments, and Dr. Stadnik does that as well.
So should I just leave it as is right now and then Stadnik will take over, or should I start the presentation?
Exactly. She'll just unmute her camera and she'll come on, address everybody, and then when you kind of go live, yeah, we'll just have this main slide on the screen, and then I'll just spotlight you your camera on your presentation.
Okay, perfect. Thank you.
Rob?
Andrew,
Yep.
so at 7:30, I'll just change the setting for who can bypass the lobby to everyone, and I hit save, right?
That's correct. Yeah. So don't worry about admitting. I'll admit all the people we need to until you click save on that option. And then everybody should be coming in without, you know, sending that ding notification.
Yeah. Okay.
All right, cool. Okay. I need to register. Hey, what's going on?
Matt, do you have your slides working? Is everything okay from a technology perspective?
Hey, Matt, can you hear us? Hey, Matt, can you hear us?
Yeah, sorry, I just didn't
Okay.
have my headphones in.
Dr. Stadnik just asked, just want to make sure you're all set in terms of your slides and technology wise.
Yep, I'm ready to go. Good morning, Dr. Stadnik.
Good morning, Matt. Andrew, are we good?
We're
Have we
good to go. Yeah,
So you'll admit everybody at 7:30 then, or whatever?
yeah, we'll do 7:31 just to make sure, you know,
Yep.
we have everybody. And then after that, Hal is gonna turn off the notifications.
Okay.
And we should be good to go. I think that's the only thing. So just a quick reminder for maybe the people in the audience when you start is just to raise their hand and we'll unmute them for Q&A
Okay.
at the end.
For Q&A at the end. Yep. Okay. All right. So you'll admit everybody at 7:31, and then I'll do introduction at 7:32, and that gives Hal a minute to get the notifications and whatever turned off.
Perfect. Sounds
Okay, sounds good. Looking forward to your presentation, Matt.
Just a reminder, let's leave everybody in the lobby, guys. Don't admit anybody until we're ready. Please and thank you.
There's some kind of signal to let me know when when we go from Stadnik's screen share to my screen share.
No, you're gonna be like that through the get-go. Like, that's how
Oh.
people are gonna join and see.
Oh,
Okay,
I see.
so just when Dr. Stanek
You'll just
introduces
switch the
yourself,
camera.
exactly.
Alright.
He turns the camera off and I'll spotlight you. Just makes you kind of a little bit bigger.
Oh, I see. All right. Okay, perfect.
Okay.
Thank you.
Welcome to the University of Ottawa Heart Institute.
Excuse me. Okay, 1 minute till I admit everybody. Okay, Hala, if you want to change that setting to allow everyone to bypass the lobby, and I'm going to admit everybody.
Okay, Andrew, I just did it.
Okay, good morning, everyone. Welcome to Wednesday Morning Rounds. Today, it's my pleasure to introduce one of our cardiology residents, Dr. Matt Cheung, who we all know well. He's in his third year of his cardiology training, and he's going to be discussing atrial fibrillation and cardioversion today. So welcome, Matt. We look forward to your presentation this morning.
Good morning, everyone, and thanks, Dr. Stadnik, for the introduction. So for cardiology rounds this week, I'm happy to present an overview of cardioversion in the setting of atrial fibrillation, as well as review some of the data collected thus far from our ongoing RCT entitled Left Atrial Imaging Prior to Cardioversion, Leveraging CT to Rule Out Thrombus, also known as LA Clot, that has been actively recruiting over the past year or so here at the UOHI. And for the title today, for those of you that didn't catch the email invitation, the play on words there. So the four major learning objectives related to the talk today that I hope we'll be able to cover is to appreciate the burden of illness related to AF and AF-related cardioembolic strokes, to provide an overview of literature that supports current guideline recommendations related to AF in the Pre-Cardioversion setting, to establish a basic understanding of image-guided cardioversion strategies, including TEE and cardiac CT, and finally, to review preliminary data from the ongoing UOHI LA Clot trial and possible future directions of this trial. In Canada, atrial fibrillation represents a significant burden of illness. Presently, atrial fibrillation is the most common cardiac arrhythmia and has an estimated prevalence of over 1 to 2% of the general population. Compounding this problem, the burden of AF is projected to more than double in 2030 as compared to the statistics in 2010. And our new improved methods of detecting both paroxysmal and silent AF are identifying more patients that may otherwise have gone undiagnosed. Together, it is estimated that nearly 1 million total Canadians will require some form of atrial fibrillation management in the near future. Although rarely acutely life-threatening, AF is independently associated with as high as fourfold increased risk of mortality, predominantly related to an increased risk of thromboembolic events and ventricular dysfunction. As a whole, these drastic effects on morbidity and mortality contribute to a substantial economic burden on our healthcare resource utilization, accounting for an annual expenditure of close to $1 billion in Canada alone. As we know, the management of atrial fibrillation can be broadly divided into two distinct categories, which include addressing the underlying arrhythmia itself and reducing the risk of cardioembolic stroke inherently associated with atrial fibrillation. With respect to the arrhythmia itself, the treatment modalities can be divided into two different but complementary strategies of rate and rhythm control. When further assessing rhythm control strategies, two prevalent modalities exist to date. One, cardioversion, either by pharmacologic or electrical means, is widely available to the vast majority of hospitals, including small to medium-sized community sites. And two, procedural catheter ablation strategies, predominantly limited to larger academic hospital centers. For the focus of this presentation, cardioversion strategies will be explored. A historical timeline of atrial fibrillation shows that it is a well-documented clinical entity for treating physicians over the past century. Before its formal identification on ECG in the early 1900s, a previously described irregular palpitation, most often associated with mitral stenosis, had been reported as early as the 18th century. Subsequent to its formal identification, strategies to regulate the arrhythmia required several decades of exploration before potential treatments came to light. The first reports on pharmacologic cardioversion in the setting of AF using quinidine were published in the late 1940s, and after that, synchronized DCCV was introduced in the early 1960s. Concurrently, the risk of cardioembolic stroke associated with non-valvular atrial fibrillation became increasingly apparent following the results of the Framingham study in 1978. Antithrombotic and antiaggregant methods of prevention would later dominate research in this field. For interventional methods, The first transcatheter non-AF ablation was performed in 1981, and its first use in atrial fibrillation did not successfully occur until 1998, following the mapping of AF triggers within the atria and pulmonary veins. It would not be until later years that randomized controlled trials were able to fully demonstrate its safety and efficacy. Finally, the CHADS-2 score was the first recognized tool in predicting cardioembolic stroke for those with underlying atrial fibrillation. In illustrating AF research milestones and the long experience clinicians have with the condition, it becomes obvious that the holistic treatment of atrial fibrillation requires significant attention to both the underlying arrhythmia and the major complication of cardioembolism. As previously mentioned, the relationship between atrial fibrillation and cardioembolic phenomenon, including ischemic stroke, has now been well established. Non-anticoagulated patients with atrial fibrillation have an estimated 3- to 5-fold increased risk of stroke. To date, the only therapeutic intervention that has been consistently and definitively shown to improve survival in the AF population is the use of oral anticoagulation. Current treatment focuses have targeted 3 major prevention strategies, which include 1, antithrombotic treatment aimed at diminishing prothrombotic effects of atrial fibrillation, 2, antiarrhythmic treatment aimed at eliminating atrial fibrillation or significantly decreasing the burden of atrial fibrillation, and finally 3, mechanical prevention aimed at the occlusion of the left atrial appendage or protecting the internal carotid arteries from thrombi. With regards to pharmacologic cardioversion specifically, the Rhythm AF International Observational Registry, published in 2014, provides the best insight into the success of various antiarrhythmic drugs in the success of cardioverting patients back to normal sinus rhythm by reviewing treatment patterns for cardioversion in a hospital setting and documenting their success rate. Here, 2 graphs are shown whereby the percentage of patients able to achieve normal sinus rhythm are listed on the y-axis, while the hours necessary to achieve target sinus rhythm are listed on the x-axis. The top graph illustrates intravenous formulations, while the bottom graph illustrates oral medications. Interestingly, even non-antiarrhythmic medications, such as cardioselective beta blockers, shown in each graph by the purple line, had modest cardioversion success rates of just over 40% and suggest that even without pharmacologic intervention, a non-insignificant group of individuals are able to revert to normal sinus rhythm without intervention. Overall, 50 to 70% of patients receiving pharmacologic intervention reach sinus rhythm. It is important to note that no trial has shown that antiarrhythmic agents prolong the life of patients with recent onset AF, and only smaller trials have demonstrated a reduction in AF-related hospitalization. Based on the data from the Rhythm AF registry, the most successful medication used to achieve normal sinus rhythm include Class 1C antiarrhythmic agents, which affect sodium channel slow association dissociation, such as flecainide or propafenone. These agents were the most effective in patients with recent onset AF and are all safe in structurally normal hearts. Other agents used for immediate cardioversion include typical agents such as amiodarone and sotalol, and have lower degrees of success, as these agents mainly control rate rather than rhythm in the initial hours of treatment, and therefore are less effective conversion drugs. In terms of local practice, amiodarone is one of the most used first-line agents used by our cardiology group, with middling results based on the Rhythm AF registry data. In the emergency department, our colleagues have recently leaned towards using Class 1A antiarrhythmic agents such as procainamide, most likely related to the localized data from RAF2, in which 52% converted after drug infusion of procainamide alone. Shifting gears, electrical cardioversion is an excellent alternative strategy that has profound efficacy exceeding 90% success rate. However, it has the downside of requiring resource-intensive procedural sedation. Numerous studies have been performed to optimize the efficacy of electrical cardioversion, and an up-to-date conventional approach include using a biphasic defibrillator, an anterior-posterior electrode placement, as well as the maximum possible initial shock energy available. While the efficacy is high, AF recurrence following electrical cardioversion of clinically non-self-terminating AF is not uncommon, and it is important to highlight the reasons behind this. The quintuple 1 rule, shown in the hypothetical curve above, demonstrates the potential time course of relapses of atrial fibrillation following restoration of normal sinus rhythm with DCCV. Immediately after the shock, a state of no conversion or shock failure can occur in up to 10% of patients in which no single sinus beat is seen, and this is thought to be related to failure of complete capture of the atria by the electric shock. In the subsequent minute, immediate recurrence of AF, so-called IRAF, may occur, which may relate to instantaneous post-shock hypervulnerability of the atria to repeat tachyarrhythmia episodes. After the brief IRAF period, the atria enter a relapse gap period in which there is usually a 1-day period of uninterrupted normal sinus rhythm, presumably related to mechanical atrial stunning, in which the atria are incapable of fibrillating. Thereafter, subacute recurrences are common over a 1 to 2 week period due to non-uniform electrical atrial remodeling that enhances electrical instability. Once reversed, electrical remodeling is completed, the rate of recurrences stabilizes, which is represented by the subsequent phase of late recurrences, during which new AF episodes appear at a much lower rate. While nearly all cases of electrical cardioversion are initially successful, 40 to 50% of subsequent AF recurrences occur during the first 2 weeks after restoration of normal sinus rhythm. Current Canadian AF guidelines have been updated beginning in November 2018 and are completed again in 2020. With respect to electrical and pharmacologic cardioversion, these have been revised, placing an increased emphasis on the heightened risk of thromboembolism in the Pre-Cardioversion setting. Prior to the update, CCS AF guideline recommendations, AF-related cardioversion was governed by the so-called 2-3-4 rule, and patients may proceed to cardioversion if non-valvular atrial fibrillation onset was less than 2 days or 48 hours, or continuous anticoagulation had been completed for a minimum of 3 weeks. Following cardioversion, patients were required to maintain therapeutic anticoagulation for a minimum of 4 weeks thereafter. Pre-cardioversion, the 48-hour rule was adopted into widespread clinical practice based on theoretical rather than evidence-based grounds. As seen by the algorithm table above, prior to planned semi-urgent or elective AF cardioversion, therapeutic anticoagulation is currently required for any cardioversion method meeting the following requirements. Any duration of valvular AF, which is defined as a mechanical valve in any position, or the presence of moderate to severe mitral stenosis. 2, non-valvular AF lasting less than 12 hours with a recent stroke or TIA event. 3, AF episodes lasting between 12 to 48 hours with a CHADS-2 score greater than or equal to 2. And finally, non-valvular atrial fibrillation lasting over 48 hours or presumed to be of unknown length. In addition to the baseline risk of thromboembolic disease inherent to atrial fibrillation, there is also a clear signal of increased thromboembolism in the pericardioversion setting that we have talked about. In comparing the thromboembolic risk of pharmacologic and electrical cardioversion, there is a limited body of evidence available to suggest a meaningful difference between the two rhythm control strategies. Analysis of the previously mentioned Rhythm AF International Registry found no difference in the rate of thromboembolism following electric versus pharmacologic cardioversion in their patient population of just over 3,900 patients, which were presumably anticoagulated. They reported that electrical methods had a slightly lower complication rate of 0.26% versus 0.39% found in the drug group in the first 70 days following cardioversion. Anecdotally, the practice here at the OHI would suggest varying levels of acceptance and comfort with regards to pharmacologic cardioversion and thromboembolic risk. While electrical cardioversion is quite unanimously deemed to be a high-risk procedure in the non-anticoagulated patient, administration of antiarrhythmics such as amiodarone did not appear to elicit the same alarms in our clinicians, most likely owing to the previously explored data that show a predominant rate control property of amiodarone, as well as a lower than expected probability of achieving normal sinus rhythm conversion. Although cardioversion in the setting of atrial fibrillation is considered by and large a safe procedure, we have now reviewed the associated increased risk of thromboembolic events, as well as emphasized that there is currently minimal evidence to suggest a difference in the risk associated with either pharmacologic or electrical means. With specific regards to electrical cardioversion, the procedural risk of stroke is felt to be even higher than the risk of atrial fibrillation alone, resulting from unrecognized left atrial thrombi that dislodge when sinus rhythm is restored. Contemporary analysis suggests a 30-day incidence of thromboembolic events as high as 2.4% in all comers without adjusting for CHAD's risk factors and in those not receiving oral anticoagulation. The increased risk of thromboembolism associated with cardioversion is postulated to be related to three distinct phenomena. The first is generation of thrombi during persistent AF episodes with subsequent embolization after restoration of organized atrial contraction. The second relates to a period of transient atrial mechanical dysfunction after the restoration of normal sinus rhythm, commonly described as atrial stunning, which is thought to be responsible for the development of new intracardiac thrombi post-cardioversion, despite the restoration of sinus rhythm, with the duration and severity of atrial stunning depending on the duration of the initial atrial arrhythmia, the atrial size, and the presence of underlying structural heart disease. The third and final possibility is that cardioversion does not directly cause stroke or systemic emboli, but rather patients who require cardioversion have transient as well as permanent characteristics associated with a higher stroke risk. The rationale for anticoagulating all patients after cardioversion is to minimize the aforementioned risk associated with restoration of normal sinus rhythm. This is supported by data from Hansen et al. Conducted in 2015 that confirmed the benefit of anticoagulation following electrical cardioversion. In the bottom table, we see that both anticoagulated and non-anticoagulated persons had an immediate increase in their thromboembolic risk in the 30 days following cardioversion as compared to the longer 1-year follow-up time interval. This increased risk was independent of anticoagulation status, but the hazard ratio was significantly increased to 2.25 with non-anticoagulated patients at the 1-month mark. This increased risk of thromboembolism was also maintained regardless of the patient's CHADS-VAS score, as highlighted by the top table. While patients with a higher CHADS-VAS score were more likely to develop a complication, the relative benefit of anticoagulation was the same irrespective of baseline risk. Anticoagulation reduced the risk of thromboembolism by about 50%, even in patients with a CHADS-VAS score of 1. But recognizing the absolute risk was still very, very low, regardless of anticoagulation status. As previously mentioned, updates to the most recent CCS-AF guidelines reflect a greater appreciation of individuals at higher risk for cardioembolism, especially those with shorter established onset of the arrhythmia, defined as less than 48 hours. Published in JACC 2013, the FIN-CV study examined over 3,000 patients with AF of estimated duration less than 48 hours who were subsequently cardioverted by either pharmacologic or electrical intervention. They confirmed that overall, the risk of cardioverting a patient with short duration AF was low at 0.7%. However, this risk varied greatly depending on patient factors and actually correlated quite well to traditional CHADS-VAS score. On the left, a bar graph chart demonstrates the total number of cardioversions performed when categorized by CHADS-VAS score, showing that the majority of procedures were performed in low-risk patients. On the right, the corresponding embolic complications that were recorded, shown in the pink bars, demonstrate a clear correlation of adverse events with increased CHADS-VAS score. Supporting the findings of the FIN-CV study, A retrospective analysis published in JAMA a year later confirmed the effects of duration of atrial fibrillation and CHA2DS2-VASc score on the occurrence of cardioembolic complications following cardioversion. Indeed, irrespective of CHA2DS2-VASc score, the risk of embolic complications was significantly higher for AF episodes lasting over 12 hours. Here, the dark blue bars show embolic complications for patients cardioverted within 12 hours from onset of AF, and light blue bars show those patients cardioverted in the 12 to 48-hour window after onset of AF. While the risk remained low for short AF episodes, there was an exponential rise outside of the 12-hour window, especially if the CHA2DS2-VASc score exceeded 1. Returning back to the CCS AFib cardioversion algorithm, the next logical exploratory point would be to provide alternative strategies to the conventional 3-week anticoagulation period. TEE-guided cardioversion, in which echocardiographic images of the left atrium and left atrial appendage serve as a reasonable alternative to those individuals that are unable to wait several weeks. And this may be due to the presence of heart failure or severe symptoms that would prohibit outpatient management. TEE has been used as the reference standard for assessing for left atrial thrombi, as well as spontaneous echocardiographic contrast and sludge that may appear in the LAA. Against surgical pathologic reference, the sensitivity of TEE for LAA is reported at between 93 to 100% and also possesses excellent specificity at 99 to 100%, with false positive rates being significantly reduced with the use of echocardiographic contrast administration. Targets for imaging include direct visualization of thrombi within the left atrium and left atrial appendage, echogenic or smoke-like swirling, known as spontaneous echo contrast, due to reduced blood flow within the atria. Functional markers, including reduced pulse wave velocities, emptying velocities, and low LA ejection fraction, can also be identified. And it has the added benefit of identifying coexistent pathology, including valvular heart disease, LV and RV systolic dysfunction, as well as alternate intracardiac thrombotic sources. TEE is a tempting and widely used method to assess for thromboembolic risks of cardioversion, and its stroke events are comparable to 3 weeks of pre-procedural anticoagulation. The landmark trial, Acute, published in the New England Journal in 2001, included just over 1,200 patients with AF lasting over 48 hours, showed that pre-procedural TEE could not reduce the thromboembolic event rate as compared to conventional anticoagulation. However, the rate of embolism within the two arms, so pre-anticoagulation as well as TEE-guided imaging of 0.8% in each arm respectively. The authors concluded that TEE-guided cardioversion allowed for early safe electrical cardioversion and resulted in actually fewer total hemorrhagic events. That is not unsurprising given the foregoing of pre-cardioversion anticoagulation. Of note, numerous studies have shown that TEE-detected thrombi are not associated with short-term risk of thromboembolism when these patients are prevented from undergoing planned cardioversion. Thus, the most beneficial indications for pre-cardioversion TEE that I alluded to a couple slides before is that it's used in desirable clinical situations in which there's symptoms that are debilitating, or there's a certain degree of urgency, as well as the adequacy of anticoagulation may not be fully ascertained beforehand. In the context of cardioversion, the strengths of TEE are well established and is appropriately considered the standard of reference when assessing for LA thrombus. Despite the excellent safety profile of TEE, with a quoted procedural risk of less than 0.01%, major complications can occur due to the semi-invasive nature of the procedure. Major risks include esophageal injury and airway compromise. Other populations who present a challenge for TEE studies include the frail and elderly, as well as those requiring significant sedation and patients with severely reduced cardiac function, significant valvular heart disease, or advanced pulmonary disease, including pulmonary hypertension, OSA, or a difficult airway. While TEE has been the standard of care in recent years, the use of non-invasive cardiac CT imaging has been increasing as a reasonable alternative to TEE, especially in clinical situations where sedation or probe insertion is challenging. Cardiac CT provides similar accuracy in detection of LA thrombus with excellent sensitivity at 96% and specificity at 92% that can be enhanced to nearly 100% when delayed imaging protocols are used. Targets for cardiac CT imaging include 1. Direct visualization of atrial thrombi, 2. Slow flow states as seen in the contrast and non-contrast phases of the study, 3. They can delineate LAA morphology, and 4. They allow for concurrent coronary artery anatomy assessment, which is often a concurrent comorbidity in this patient population. Currently, a cardiac CT costs roughly $242 and takes approximately 5 to 10 minutes to complete an entire study. While CT scanners are readily available in nearly all medical facilities, cardiac CT expertise is required, which is usually only available in tertiary or quaternary care centers. Cardiac CT has the main advantages of being a non-invasive procedure that is extremely fast and does not require any procedural sedation. One of the main perceived advantages include concomitant coronary assessment. However, this requires adequately controlled ventricular response. Important to note, heart rate is not a barrier to evaluation of the left atrial appendage, with no heart rate target needed, and we can easily image them if their heart rates exceed the traditional sort of 75 beats per minute cutoff used when coronary artery assessment is required. In terms of pitfalls, the amount of iodinated contrast dye is comparable to that of a diagnostic invasive coronary angiogram, or about 100 cc's of contrast media. The associated radiation exposure for the vast majority of patients is approximately 6 millisieverts when delayed imaging protocols are used that are in every study here at the Heart Institute, and comparable to the amount of radiation required for a routine CT chest. At the UOHI, the cost, as I mentioned, is about $313, and at worst is extremely comparable to the cost of a TEE. In order to gain insight into the use of image-guided cardioversion in the atrial fibrillation patient population, the LA Clot Study was started. This is a randomized control trial that aims to assess the utility of cardiac CT to improve patient access to image-guided cardioversion and provide timely care for those who are hospitalized with AF-related issues. The results of this study could have significant impact by improving patient quality of life and timely access to cardioversion. This research is novel because it will be the first to demonstrate in an RCT manner that cardiac CT can be used as an alternative to TEE. More importantly, it also has the potential to demonstrate the cost effectiveness of CT that would be extremely attractive to all stakeholders given the growing financial burden of healthcare in Canada. In terms of outcome measures, we have slowly been collecting data in patients hospitalized with atrial fibrillation with regards to their timely access to A, intended imaging modality, B, the actual electrical cardioversion procedure itself, as well as C, their total length of hospital stay. To assess quality of life objectively, both the generalized quality metrics, including the European Quality of Life Group EQ5D5L score, and the atrial fibrillation specific AF impact score were collected at the 3 time points previously mentioned. As a measure of safety, adverse events will also be recorded and to verify that both imaging modalities are equivalent in terms of their safety. For enrollment, predefined inclusion and exclusion criteria are generally super easy and comparable to other trials studying AF. The vast majority of exclusion criteria used were related to safety, mainly to avoid cardioversion delay in an unstable patient. And finally, commonly agreed upon contraindications to both TE and cardiac CT imaging modalities. For our cutoff, acute renal failure is often a clinical consideration that we have, and the eGFR cutoff that we used is 45. It was also estimated that 100 patients would be enrolled in our study in order to have some meaningful data. And currently, a total of 37 patients have successfully been enrolled, which is a slightly disappointing number, but may relate to the barriers of the ongoing COVID-19 pandemic. For the study protocol, a flow diagram is shown here in which patients are randomly assigned in a one-to-one fashion to either the cardiac CT arm or the conventional TEE arm, and therapeutic anticoagulation is initiated as determined by the referring physician. Following their pre-specified imaging modality, an epic order was placed as stat within the system with the heading of LA clot rule out left atrial/left atrial appendage thrombus for purposes of cardioversion. Following completion of the randomized imaging modality, patients with no thrombus detected then went on to have electric cardioversion. For the study, TE will be performed as per clinical routine using multiple standard planes to rule out LA and LAA thrombus. Echocardiographic analysis will include LAA emptying velocities and grading the severity of LAA spontaneous echo in addition to the identification of established thrombus. The severity of smoke or spontaneous contrast will be later graded on a 4-point scale to see if there's any signal there. In the above cine images, we demonstrate identified LAA thrombus in one of our randomized patients. Here, X-plane images are shown at the mid-esophageal level, demonstrating spontaneous echocardiographic contrast and a large LAA thrombus with multiple hypermobile components seen. As per local protocol, pre-cardioversion cardiac CT imaging involves a non-contrast enhanced prospective ECG-triggered image acquisition for all randomized patients. This is subsequently followed by a contrast-enhanced prospective ECG-triggered image acquisition, and thereafter we collected delayed CT images acquired at the 60-second mark after initial contrast was administered. In the above imaging panels, the left-sided images demonstrate contrast-enhanced CT images, while the right side demonstrates delayed CT images. Top images correspond to an axial plane at the level of the left atrial appendage, while the bottom images demonstrate sagittal views also at the level of the LAA. Here, a large LAA thrombus is seen in the contrast images and later confirmed due to its persistence on the delayed imaging. Now I'm happy to share some of the preliminary data that we have. So again, for the 37 recruited patients thus far, a brief summary of baseline demographics is outlined. Table 1 demonstrates a largely homogeneous group of patients in each arm that are predominantly patients in their 60s, predominantly male, overweight or obese based on their BMI, and usually presented with their first known episode of atrial fibrillation, meaning that this was a new diagnosis at the time of enrollment. CHADS 2 score and CHADS VAS score were equal for each group with an estimated moderate annual risk of cardioembolism. In terms of their cardiac function, LVEF was mild to moderately reduced, and atrial size also came out to be moderately dilated for both groups. And important to note, if we compare to the New England Journal acute trial, these baseline characteristics are very, very similar to that patient cohort. Table 2 here demonstrates the reported symptoms at presentation, with the largest proportion of patients reporting dyspnea as the most common complaint at 65% in each arm, and a lower than expected incidence of reported palpitations and syncope that one would expect at 25 to 30% and 0% respectively. This is an interesting statistic to bear in mind, given that the study population, again, is in a hospitalized setting, largely suggesting that the majority of referred patients in the study have some degree of previously known LV systolic dysfunction, or that there was a clinical concern for congestive heart failure, or the possibility of tachycardia-mediated cardiomyopathy, necessitating inpatient management of their identified arrhythmia as opposed to outpatient management. Table 3 here highlights the timeliness of pre-specified endpoints for each imaging modality, including time to complete a diagnostic imaging test, time to cardioversion, and time to hospital discharge. Importantly, the hours calculated for all 3 endpoints already accounted for the removal of weekend hours in the event that a patient was, say, enrolled on a Friday going into a weekend, and the limited availability of appropriateness of on-call studies in our building. We just took out Saturdays and Sundays from these hours. Even in our small sample size, cardiac CT was able to establish a p-value significance when it came to randomization to completion of the pre-specified imaging test at an average time of 6 hours in the cardiac CT group, as compared to just over 24 hours in the TEE group, and a trend towards significance when assessed again at a later time to cardioversion. Given the previously described attributes of both imaging modalities, this is not an entirely unexpected finding, and most likely relates to the need of TEE, such as an NPO status before the procedure can be performed, and the constraints of our own echo lab, given that there's a small number of daily slots available, which currently sits at 6, not counting on-call studies that can be performed, in comparison to the capabilities of our CT department, which obviously can handle a much larger volume of studies. In graph form, the temporal relationship of the previously reported EQ-5D quality of life metrics were plotted against the 3 time points. Again, randomization, hospital discharge, and 1-month follow-up is shown here. In the dark blue line, we have the results of TEE, and in the light blue, we have cardiac CT. Again, this is a generalized quality of life scoring survey that has been well established, but not specific to atrial fibrillation. Across, it's been used across multiple disease entities, both in cardiology and non-cardiac related subspecialties. We see here that CT did slightly better at the time of discharge, although the p-values did not reach significance, probably owing to a large spread across a small patient sample size. Similar to the previous graph, the temporal relationship between the AF impact score, so again, this one is now more specific for atrial fibrillation, are plotted against the same 3 time points. In contrast to the generalized EQ-5D data, a lower AF impact score denotes a more positive experience. So whereas the previous graph showed an uptrend, this one shows a downtrend. Both indicate that patients did better with time after cardioversion. These scores were comparable across the two groups, and again, p-values did not reach significance. The LA Clot trial is still actively enrolling patients, and one of the main barriers to its completion remains a slow enrollment rate, which may be a factor of the ongoing COVID-19 pandemic or unawareness from our cardiology service about its existence, which is why I'm giving the talk today for purposes of helping our enrollment. In terms of limitations for generalized applicability, fortunately or unfortunately, we know that cardioembolic event rates following electrical cardioversion are very low, and it will be difficult to assess the safety profile of CT versus TE without having recruitment numbers that are massive. In addition, we recognize that each imaging modality has hospital-specific protocols that could be optimized for the purposes of the study, but we chose instead to follow routine clinical practice that is unique to our own cardiac center, and this may not be the case in non-academic or non-Canadian centers. So, for instance, you know, a full TE study is not necessarily required to rule out left atrial appendage thrombus. We could easily just put a probe down, answer the clinical question and get out. But here we sort of do a full study regardless of the indication. And for CT imaging, as an example, you know, we could use less radiation and the protocol could be altered to simply just answer the question. But if we can, we try to provide supplementary data to the physician taking care of the patient. Upon completion of our study, our hope is to expand the study population to other important clinical settings, including, just to name a few, the emergency department, outpatient settings, possibly dividing into an intensive care unit setting versus a ward cardiology specific setting. If the results demonstrate a signal of improved timeliness or quality of life, further studies may be required involving, you know, a multi-center approach with multiple hospitals in Ontario or possibly even outside Ontario to confirm these findings in a more generalizable population. Finally, an untapped study population of interest may be these pre-PVI ablations that would also be of interest. So to summarize, atrial fibrillation has a significant burden of disease among Canadians and is only expected to rise. In addressing the underlying arrhythmia, cardioversion, either pharmacologic or electric, has been a mainstay of therapy. However, it is known to carry a major risk of debilitating ischemic stroke due to cardioembolism in the non-anticoagulated setting, and there is an increased body of evidence that would suggest even short durations of atrial fibrillation confer increased risk of complication. TE is the reference of standard for image-guided cardioversion, but the scientific evidence supporting its wide use is nominal. And with the recent revisions to the CCS-AF guidelines leaning towards a more selective population that can undergo immediate cardioversion, it is most likely that there will be a hesitancy towards immediate cardioversions from our colleagues in the emergency department, and the downstream effects of this would result in increased referrals for AF-related hospitalizations and requisitions for timely TE procedures. Our hope is that LA Clot may be able to show that cardiac CT is a viable option in image-guided cardioversion with the potential to improve patient quality of life and cost-saving measures for the healthcare system. But more importantly, you know, provide another tool in the arsenal for the cardiologist in performing safe cardioversion by limiting the thromboembolic risk. And that's all I have. I'd like to thank Dr. Ben Chow, who served as my PI for this ongoing trial and who's present today, as well as the innumerable staff who sort of helped me consolidate this information that I'm happy to share with you today, including Dr. Burwash and Dr. Froschel.
Thank you, Matt. That was excellent. So we'll open up the presentation for questions. If you do have a question, if you could please raise your hand using the little raise hand button, and then we'll unmute your microphone. While we're waiting for people to submit their questions, Matt, I do have a question for you. You know, we often we'll see patients come to the emergency department in atrial fibrillation who, you know, maybe have a little bit of heart failure, but are otherwise hemodynamically stable, and they have not been on anticoagulation. And so they're appropriately started on anticoagulation and admitted, and then not infrequently, I've seen these patients started on amiodarone. And you nicely showed a graph there demonstrating the amount of cardioversion that occurs with, you know, medical therapy. Do you think this is appropriate practice?
Thank you for the question. So just to summarize, you know, we have a non-anticoagulated patient who's coming in with symptomatic AF or the result of complications related to the underlying arrhythmia. And the question is whether it is safe to start pharmacologic antiarrhythmic drugs. So that was a question that I had to ask a lot of the staff that I work with here. And as I alluded to in my slides, I don't think that there is general consensus. But based on the information that I've researched here, there's nothing to say that that's safe. So at the end of the day, I think it's the clinician at hand. My personal feelings towards this is that if you can't reliably show data to show that the rate is lower than DCCV, my preference is to avoid that strategy until you can definitively rule out thrombi. But I know that there is variability to practice, and I was really hoping that this question would be answered because we struggle with this as residents. You know, you could have 10 staff or work with 10 staff with the exact same patient, and I think you would get maybe 5 saying that that's okay and 5 saying that that's not okay.
Yeah, that's my sense as well.
Yeah.
That's my sense as well. Dr. Beauchesne has a question.
Yeah, thanks, Ellie and Matt. That was a great talk. I just, I think I might have missed, but I'm just trying to understand the numbers for the trial and the power calculations. So, as you alluded, the actual event rate of clot is pretty low. And I think you're trying to do like a non-inferiority kind of thing where CT is as safe as TE. And so what are the numbers? Like, how many people do you have to recruit to show that it's safe?
So in terms of actually commenting on safety, I don't think we'll be able to be powered to do such. So far, the event rate has been 0, which is good. But, you know, like you mentioned, we would require thousands and thousands of patients. So I think we're just building on previous literature to suggest that the diagnostic accuracy of CT is comparable to TE. But I think to show that in a randomized control trial format would just not be possible given our resources.
And Matt, I can add if that's okay. So it's to Luke. So it's a good question. So as Matt alluded, we're not going to be able to demonstrate superiority in terms of safety. So it's more a timeliness in care study. You know, can we actually improve time to care, shorten length of stay in hospital, potential improvement in quality of life. So let's call it softer outcome measures.
And then Ben and Matt, do you, I guess, you've got patients that are randomized to each group, but how do you know you're not missing clot in one group?
How do I know that we're not missing clot in one group? I guess we would have to look at the adverse event rates as a surrogate. So there is a caveat in our study that if we do identify potential clot, so one thing that I didn't talk about was the imaging protocol used for CT. So oftentimes you can get swirling within the LAA, and that can be misinterpreted as the presence of thrombi. And for those wishy-washy studies, we do go on to TEE to sort of confirm it if it's not slam dunk. So I hope that answers your question.
Yeah, that does. Okay, but that's excellent. We will try and keep this study in mind so we can help you recruit more patients. If there's no more questions today, we'll stop there. Thank you very much, Matt and Ben, for the presentation today. Next week's rounds will be presented by Dr. Angel Fu, again, one of our C3 cardiology residents. So thank you for joining today. Have a good week. We'll see you next week.